Yeah, good morning, sir. Very nice to see you.
Me too. Thank you
Welcome
very much.
to NIC. So, let me introduce today our guest from Japan, Dr. Shairo Omara. Is a professor of medicine and chief cardiovascular medicine. So, very happy to interact with you, sir.
Yeah,
because
me too. It's a great honor for me to be invited by CSI at this time. So I'm very glad to see you. Thank you.
where all medical students are very familiar with Kawasaki, because Kawasaki disease with multiple aneurysms. Today we will talk more about the intravascular imaging usefulness.
Okay.
So, sir, in Japan, I came almost 3-4 times. Like I visited Tokyo, even Nagoya. So there they use lot of intravascular imaging. So, but in India, and not only in India, in other parts of the world, intravascular image is not that much used.
Yeah, that's
if you
right.
see the statistics, even in any international trial, if you see, hardly 15 to 20% of the trials showed the intravascular image usefulness. So, what is your observation, sir? Why in Japan they are using almost 90%? I think more than 90%.
Yeah, more than
usage.
90%, almost 100%.
Yeah.
Yeah. Previously, PCI was performed by the guide of coronary angiography. However, recently, intravascular imaging such as IVAS and OCT has been used for the guide of coronary intervention. The reason for the increased use of the intravascular imaging is the improvement in the quality of PCI. By using OCT, we can optimize the procedural results in each patient, and it is anticipated that OCT also can improve the clinical long-term outcome in patients with coronary artery disease.
Sir, intravascular imaging, particularly recent IVAS data, showed very clearly if the complexity of the lesions are more, the benefit is much more.
That's
like
right.
Compared to single vessel disease, two vessel disease, patient is having a multi-vessel disease or bifurcation lesions,
Yes, that's right.
left main showed more benefit, particularly in terms of MACE rate.
That's right.
What is your observation, sir? And do you use for all patients or only for complex PCA in your personal?
So, as you said, if the lesion is very complex, intravascular imaging helps the physician to achieve optimal results. However, if you use coronary angiography only, it is very difficult to differentiate whether this lesion is simple or complex. So, in order to differentiate the complexity of the coronary lesion, I think intravascular imaging is very helpful. So if you think that this lesion is very simple on angiography, but OCT may reveal that the complexity of such angio-based simple lesions.
Sir, in your personal practice, in which subset of patients you prefer OCT, and in which subset of patients you would like to prefer IVAS compared to OCT?
Yeah. So the most good indication for OCT is the bifurcation lesions. OCT pullback of OCT is faster than IVAS, so the longitudinal reconstruction image is very clear in OCT. So if we see the longitudinal OCT image, we can clearly see the morphology of the bifurcation lesions, shape of the carina, as well as the bifurcation angle. These also have effect on the successful PCI procedure. So I like to use OCT, especially in bifurcation lesions. And also in ACS patient. So the ACS, as you know, the basic mechanisms of acute myocardial infarction is classified into 3 categories. One is a plaque rupture, and one is plaque erosion, and one is calcified nodules. The clinical outcome and the treatment are different among the basic plaque morphologies. I think IVUS cannot precisely diagnose the basic mechanisms, but OCT can clearly show the difference of the basic mechanisms. Based on the OCT findings, we can change the strategy of the PCI as well as the long-term medical treatment.
So research data more in favor of usage of OCT compared to IVUS, particularly in managing calcified lesions. Like I see, IVUS will not penetrate through the calcium,
That's
so
right.
it leads to a shadow effect.
That's right.
And at the same time, because the depth of the calcium cannot be measured by IVUS very accurately.
That's right.
But OCT, they say
Can
that you
measure.
can assist. Particularly, what we are interested as interventional cardiologists, mainly we are interested in superficial cares
That's
rather than the deep calcium.
Yeah, you're right.
So the superficial thickness, they say like more than 500 microns, usually undilatable.
That's right.
In some studies, they have quoted 650 microns.
That's right.
Similarly, length more than 5 millimeters. The longer the lesion, the more likely a patient should require the rotablation. Similarly, the arc, like calcium arc, is it 90 degrees, 180, 270 degrees? Like if, but many people, most of the data were supportive in favor of the IVUS because of the long-standing usage of this one. But do you see that definite change in usage of the OCT versus IVUS in calcium? And what is your personal experience, sir?
Thank you very much. I totally agree with your opinion. OCT, I am confident that OCT is superior to IVUS, especially in calcified regions. As you said, the OCT can measure the thickness and arc and the longitudinal distribution of calcium deposition very precisely. And based on the volume of the calcium, volume of the calcium is important predictor of the poor long-term outcome in patients with coronary artery disease. So assessing coronary volume by OCT is very useful, not only for the stratification of the PCI, but also the patient care in chronic phase.
Yeah, some type of patients we see angiographically, but sometimes we cannot decide based upon the angiography, like a Spartan's dissection, or is it because of the recurrent thrombus, or simple thrombus, or sometimes calcium can mislead like a thrombus.
Yeah, that's right.
So when these are ambiguous lesions, so in ambiguous lesions, when you see an angiography, so do you prefer to use the imaging, and which imaging is you prefer, like particularly recurrent thrombosis like?
Yeah, thank you very much. Ambiguous findings on angiography should be clarified by OCT, I think. Frequently, IVUS cannot differentiate what is happening in the coronary artery because of the relatively poor spatial resolution. But OCT has 10 times higher spatial resolution in the comparison with IVUS. Such characteristics OCT clearly show what is happening in the ambiguous angiographical regions. So I prefer to use OCT.
The one disadvantage, many papers also published, particularly like if the patient is having a large plaque burden, particularly lipid atheromas, like with thin cap fibroatheromas, where they have more than 3 quadrants of like a lipid pool.
That's right.
Such patients you may not see very clearly all trilaminar structure. You may not see the adventitia. So when you are doing the PCA in such patients, how will you take the landing zone? Suppose the patient is having a large plaque burden, and suppose if the patient is having diffuse disease. So even sometimes, particularly in India, we have a small vessels, diffuse lesions, diabetic patients where they have entire coronary disease. In such cases, and what is the basis for choosing the landing zone?
Yes, that's right. Thank you very much. So the perfect landing zone is a non-atheromatous plaque, but this is very rare. So we have to put the stent landing zone in the presence of the atheromatous regions. However, so if we see the calcification or the lipid pool more than 90 degree, we have to avoid the implantation of the stent edge in such regions. If we put such stent edge in such regions, we may have the stent edge dissection or under expansion. So for such purpose, OCT is superior to IVUS because of the tissue characterization of the atheromatous plaque. And also, I want to say that the OCT has some limitations in comparison with IVUS. One is the use of additional contrast medium. So in my daily practice, if we perform the OCT guided PCI, we have to use more, approximately 30 ml, 30 cc additional volume of the contrast medium in the comparison with IVUS guidance. However, based on our large cohort, there was no significant difference in the development of contrast-induced nephropathy or the worsening of the renal function between two arms. So in daily practice, additional 30 milliliter contrast medium is not so significant problem in patients with mild to moderate or normal renal function. In patients with severe renal function, I think we should try to decrease contrast medium as much as we can.
Sir, how safe it is technology-wise, like is when you are doing OCT, because we are sending like a catheter, thick catheter, we are inside the carotid. Is there any incidence of dissection or embolism or
so very rare. So it is reported that the incidence of vascular complication during OCT or IVUS is less than 0.1%. So I think intravascular imaging is safe modality.
And like follow patients with PCI, which one you prefer? Patient like a stent thrombosis or like a uncovered stents or patient is having a restenosis during PCI follow-up, like IVUS versus OCT, your comment on this?
Of course, I prefer to use OCT because, as I said to you, the spatial resolution is 10 times higher in OCT. So OCT can detect the malapposition in the chronic phase and the mechanism of the destenosis or late sense thrombosis. So we have, I think it's better to use OCT instead of IVUS in the follow-up patient.
So some studies also shown very clearly if a stent fracture leading to restenosis. So imaging wise, when you take a three-dimensional OCT, it is also showing is it totally got into two pieces like a fracture. They say that OCT also detects the stent fracture very nicely. Your personal experience about this one?
Yeah, thank you very much. So because of the very fast pullback speed, OCT can reconstruct the very fine and very exact longitudinal reconstruction. Because of the IVUS pullback is very slow, so there is an overlap of the longitudinal image. So I think OCT is not able to detect the stent fracture in daily clinical practice. By contrast, OCT is very sensitive for the detection of the stent fracture in chronic phase. But the basic is the fluoroscopy.
Suppose the patient is having a spontaneous coronary dissection. So in that, in those cases, when you use OCT, you have to give a high volume, high pressure injections.
That's right.
Does it make it worse?
Yeah. So there are some case report indicating that the OCT detected the ostium of the dissection and clarify the mechanism of the spontaneous coronary dissection. However, I think routine use of OCT for the suspected spontaneous coronary dissection should not be performed because of the possibility of, as I said, to use the worsening of the coronary dissection. And also, if the intima is very normal, sometimes OCT underdiagnose the development of spontaneous coronary dissection. So I think in clinical case, first IPAS may be better for the diagnosis of the SCAD.
Suppose you are not aware of the exact test what was used earlier. Suppose if the patient is coming for PCI follow, okay, you did the 3D OCT. So based upon the links and joints, connectors, so they say this is the pattern, this is like a Exine stent, this is like a Orcedo stent or Promiscuous. So what is your personal experience with this one? Can we based upon the OCT image, can we say this is the Exine stent like that?
You are
Some
right.
people report that actually
Yes.
the diagnosis of the stent, even labeling can be done.
Yes. So we have to think about the one possibility that if the stent is totally buried with neointima, it is impossible to detect the stent shape even with OCT. However, the neointima is very, in case with thin neointima, OCT can clearly reconstruct the shape of the stent strut, which can determine maker, manufacturer of the stent.
Suppose after procedure, like after you have achieved adequate mean luminal area, mean surface area, so suppose still malapposition is there. But once you achieve the adequate stent area, is it okay with it, or we have to oppose it fully?
Acute malapposition just after stent implantation is not the independent predictor for the development of future late stent thrombosis. However, if the patient has very significant malapposition after the stent implantation, if patient develop another coronary lesions after stent implantation, in such case, malapposed strut is the obstacle to the next procedure. So I think if OCT shows the significant malapposition more than 500 micrometer, it's better to use larger non-compliant balloon to decrease the degree of stent apposition.
Each study is saying a different criteria for like malapposition. Like a Clio PCA, they said 200 microns. Some studies said in 360 degrees, 360 degree is there, like 366 microns are there. Almost 100% will not heal. But if it is less than 360, almost 100% malappositions will heal. So what criteria you take? 500 microns?
Yeah, so in my personal experience, malapposition more than 500 micrometer cannot be attached or covered by tissue in chronic phase. This is my personal impression.
Regarding under expansion area, like Illumini study, 3. They put a strict criteria, like a proximal of more than 90%, distal of more than 90%, compared with the distal landing zone, proximal landing zone. But even in that study, though they have put for successful criteria more than 90%, but even in their study, they achieved only in 60% of the patients. But subsequently, they said at least 70% should be achieved to say there is no under expansion. What is the minimum area you see, sir, when you do the under expansion? But sometimes it is not possible to get the 90%.
That's
maybe
right.
because of the thickness, maybe because of the calcium. But Clio PCA clearly mentioned the distal and proximal mean luminal area should be more than 4.5 square mm. When it is less than that, those patients were having ulcer with more mace rating. So what is the criteria you consider?
Thank you very much. As you said, the minimum lumen area after stent implantation is the most significant predictor for the poor outcome in chronic phase. So we have to improve the stent area and stent diameter as much as we can before finishing the procedure. And recent expert consensus document from EAPCI, European Society of PCI, have shown that the relative stent stenosis less than 80% is a predictor of worse outcome. So they recommend to improve the relative stent minimum area more than 80%. This is, I think, the most well-known criteria for the stent expansion. And also, the minimum stent area is itself is important. However, it's dependent on the where the stent is implanted. So if the stent is implanted in the proximal part of the coronary artery, the minimum stent area should be larger than the stent implanted in the distal part. Makes sense? So I think important thing is the relative minimum stent area more than 80%.
How do you foresee the future development of OCT? Like the one main disadvantage, very high resolution, but penetration is only 1 to 2 millimeters. Some more like a more penetration like that.
So, but as I said to you, the most important thing for the prediction of patient prognosis is the lumen area. So important thing is in clinical settings, important thing is the lumen area. So OCT is very sensitive for the measurement of lumen area. So it's better than IVAS. So this is the first priority of the IVAS. But theoretically, they say that it is impossible to improve the penetration depth of the near infrared into the tissue. However, I hope that the application of artificial intelligence, AI, may improve the diagnostic capacity or the depiction of the tissue in the deeper side of the vessel, even in OCT. This is my expectation.
Thank you very much, sir.
Thank you very much.
For clearing our doubts and highlighting many things about the intravascular imaging.
Thank you so much.
Thank you very much. Thank you.
Thank you.